Start the recording, please. I just can't find it.
It started.
Okay, thank you.
Thanks, Jim. So, we're just sorting out a few technical issues like we always have to do at the start of these sessions. Thank you very much for making the effort to come along this morning to join us to find out the latest research and insights into transverse myelitis with Dr. Cynthia Wang. My name is Ross Duncan. I'm the Executive Manager for Member Services with Spinal Life Australia. I'll be the MC rather quickly today. I'll hand it over to our Chief Executive Officer in a minute after I run through some formalities. Then we'll cross over to Dr. Cynthia Wang. So before we get started, I introduce everyone. As we do, we like to acknowledge the traditional owners on the land in which we meet today and acknowledge the efforts of the elders past, present and future to maintain, protect and promote the Aboriginal and Torres Strait Islander culture. With that done, the exit in the case need to evacuate from the building today. The way you come in is the way you get out of this room, and then go out through the front door out into the car park and congregate there, and we will come and sort you out and get you where you need to be. There's fully accessible toilets at both ends of this building, internal, so you can either exit this door on your right hand side or on your left hand side, and if you go to the corridor down this way, there's accessible toilets, and just straight across this corridor there's accessible toilets as well. So that's the housekeeping out of the way. I'd like to introduce Michael Powell, the Chief Executive Officer of Spinal Life Australia, to give us a little bit of background about Spinal Life Australia, what our plans are for the future and our strategic direction. Michael, thanks.
Well, good morning to all, and thank you, Ross, for the introduction. This is my third chat to our transverse myelitis group in 3 years, annual. That's good. I think the first one was about 2 weeks after I first arrived in the role as CEO, and I didn't know anything about it, but I stood up here and I said, "That's really great. You know, our organisation is founded to do wonderful things for people with spinal cord damage, including transverse myelitis and post-polio." But over the last 3 years, I've learnt more. I've listened into the presentations as well. I won't be able to do that today. I do apologise. But I would like to start off. I've got a few comments here to make. Spinal Life Australia is a leading provider of advocacy, therapy and support services for people with spinal cord damage or related physical disabilities. Our organisation was formed in 1960 when a group of people with paraplegia and quadriplegia discussed how they could advocate for themselves. So they set up our organisation at that point. So we've been around a long time. Our organisation's belief is that everybody with spinal cord damage in Australia should have access to healthy living to allow equal participation in society. This belief influences our work now and into the future. Our personal support services are delivered by more than 800 staff across Queensland and assist people both in their homes and out in the community, while our allied health team works with clients to source the latest equipment and that suits their needs and lifestyle. We also provide member services, including access to community networks, and campaign for accessibility and inclusion as part of our local, state and national advocacy efforts. We currently have almost 1,500 members for our organisation, and we've been working with them to help them influence their communities and become more inclusive for everyone. Through the support we provide, we assist people to live more independently as part of their trusted team for life. Recently, we've expanded to offer more of our clients and members in regional Queensland, and in the last 6 months have opened offices in Bundaberg, Rockhampton, as well as increasing our presence in Toowoomba. We've been providing advice and guidance for our members and clients as they prepare and enter the National Disability Insurance Scheme. And looking to the future, one of our biggest projects yet is coming to far north Queensland, called the Spinal Life Healthy Living Centre. And those of you who are in our office would have passed the diorama or the model on the way in. A $12 million facility, which is primarily devoted to hydrotherapy, assisted gymnasium, and therapy and rehab clinic rooms. with accommodation as well. So for us, it's our first major development in quite some years. We're also expanding our member services, and we're going to Perth to provide people in West Australia with better supports for people living with spinal cord damage from about July of this year, which is only a month away. And I'd like to recognise Louise Remilton, the volunteer facilitator for Spinal Life Australia's Transverse Myelitis Network. I'm looking around. Oh, up the back, Louise. Yeah. These events are an opportunity for us to engage interesting guest speakers on the subject of transverse myelitis and to learn more about what our members want and how they are influencing their local communities. We would rather be a supporter and an influencer. Obviously, we can't do everything, so if we can engage people to influence their communities, we can spread our effect many times over. We're a member-based organisation with members with spinal cord damage as part of our board of directors. And I'm always asking whether people are interested in being on our board. Our board is a skills-based board, and again, we are always looking for people who have the time to participate as a director. We have the skills that our board are looking for, and if you go onto our website, you will see the skills matrix that our board are looking for. And if you have the opportunity, the time, and the capacity, we would love to hear from you. And the final thing I'd like to close on, if you are not a member of Spinal Life Australia, please become a member. It's the huge cost of $10 a year, but you get far more than just than what your $10 pays for. You get our Advocate magazine 4 times a year. You get access to our member networks. You get support. You get advocacy, both organisational and individual, if you need it. And what we want to have is more funded members, because when we go to government at any level and we say we represent 1,000 members, 2,000, 5,000, 6,000, the more you have, the more they listen. And just recently, you may have been watching the Queensland Rail Trains issue, and we got 16,000 people across Queensland, maybe a little bit wider, to sign our petition to say, look, it's just not good enough not to have accessible trains at this point in Queensland's life, I guess, is quite appalling. And so to mobilise 16,000 people, we were pretty happy with that. So become a member. If you're not a member, $10. I know it's money, but over a year, it's like a couple of cups of coffee. Thank you very much, Ross.
Thanks, Michael. I'd also like to acknowledge Louise Remilton, the volunteer facilitator for the Transverse Myelitis Network. Through Louise's efforts over the years, we've built up a unique, I think, relationship with the University of Texas Southwestern Medical Center, which results in Dr. Ben Greenberg participating in annual seminars on a Sunday night over there. And I'd like to thank Dr. Wang for also volunteering, I guess, what is also her Sunday night to join us today. So if I give you a bit of a biography, our organisation is really fortunate to be able to access people like Dr. Greenberg and Dr. Wang. The reason you see the screen up today is because we're recording this session as we normally do, and we're also webinaring it out so people can log in from all across Australia who we've sent invitations to. So we'll they'll be able to ask questions online and things like that. So we're trying to not only share this with the people in the room today, but more widely. So I'll hand over to Dr. Wang just in a minute after I read a little bit about her impressive biography. So Dr. Wang received a medical degree from University of Texas Southwestern Medical Center in Dallas and completed a pediatrics and pediatric neurology residency at Mott's Children's Hospital, University of Michigan Health System in Ann Arbor, Michigan. Dr. Wang is currently a James T. Lubin Fellow under the mentorship of Dr. Ben Greenberg at the University of Texas Southwestern and Children's Health. Her research is a prospective longitudinal study on acute disseminated encephalomyelitis to identify the clinical characteristics, treatment methods, and follow-up interventions that are associated with better and worse patient-centred outcomes. So Dr. Wang's generously given of her time today to share with us some updates in transverse myelitis and related neuro-immunological disorders. So over to you, Dr. Wang. Thank you very much for your time.
Okay, great. Thank you so much, Ross, for the kind introduction, and thank you so much for the invitation to address your organization today. I'm not Dr. Ben Greenberg, unfortunately. Certainly he will be missed, but hopefully I can fill his shoes in some way and you can learn something new today. So I'd like to start by talking about the themes of the talk. Let's see, after I show, these are my disclosures. I'm very biased. I love the Transverse Myelitis Association. It sounds like Spinal Life Australia is meeting a lot of the same needs in Australia, and that's a fabulous thing to have, to be supported in that way. So sort of my objectives for this talk is first to give you an overview of sort of where we are currently in terms of our understanding of transverse myelitis. And that will begin with sort of an overview of transverse myelitis, talking about the CAPTURE study that's been led by UT Southwestern. Acute flaccid myelitis is a different subtype of myelitis that we've really learned a lot about in the last couple of years. This other syndrome called myelin oligodendrocyte glycoprotein antibody syndrome is really new in the last few years, and we're learning a lot of interesting things that can affect how people are managed. And then part of my screen is off. Let me see if I can. Yeah, I moved it a little bit. And then in terms of what I think most people who've had idiopathic transverse myelitis sort of care the most about is, what sort of new treatments, new modalities of therapies are being offered or maybe coming online in the next few years. And then I just wanted to talk about some of the projects that the Transverse Myelitis Association has going on, including the Eclipse Fund and the family camp that they do annually. And then I'll be happy to take any questions at the end. And throughout the presentation. Again, I can't see you, so it's a little awkward, but please, if I think I can hear everybody fine, so if anybody has a question, just please feel free to shout out. So starting with, what we know about the disease, and I think this will be a review for many of you, but I think for the people who are maybe more newly diagnosed or people who could use a refresher, I just wanted to go through some of the principles of the condition. So transverse myelitis also goes by names of myelitis or inflammatory myelopathy, and literally it just means inflammation of the spinal cord. It doesn't say, exactly why it happens, and we know that in certain cases it can be from an infection, directly from an infection, or happen after infection has, attacked the body and left the body. And there can be various severities of inflammation of the spinal cord, including maybe injuring the myelin, which is the insulating coating around the neurons, or it can actually be so severe that sometimes the wire, the cable itself can get cut, and that's the axon that I'm referring to. It seems to be broadly prevalent in any age group. Male and female are roughly equal, and it does represent a fairly rare disease with 1 to 5 cases in a million people. I think one distinction that is important is that there are recurrent forms of myelitis, which can be a part of a syndrome such as multiple sclerosis, neuromyelitis optica, spectrum disorder, and acute disseminated encephalomyelitis. And then when we say transverse myelitis, we usually refer to monophasic myelitis, which is a one-time immune event, and then it seems the immune system corrects itself and never strikes again. And the name for that also is idiopathic myelitis, meaning we don't really know the cause. It seems like infection may be related because in about half the cases, there's a preceding infection before the transverse myelitis event. The recovery, again, is quite variable. Some people, you would never even know they had transverse myelitis and they're back to their normal activities. And it can completely range to, people who have quadriparesis and are pretty impaired in their daily function. So I think the nervous system can be quite complicated for anybody, even me. So I think one way I like to simplify it is to think of analogy, which is the spinal cord is sort of a highway that connects the brain down to the muscles that control our body, or the nerves that perceive sensations. So in terms of highways, I don't think Dallas represents the best example of a simplistic view, so maybe Brisbane would be a little bit better. This looks much nicer right now than it's literally 100 degrees outside here. It must be much nicer in your season. But yeah, I think the analogy of a highway, I think, is intuitive to many people. So if we think of, and I hope you can see my cursor, I may be using it off and on. So if the brain is here, and this is sort of a kind of a illustration of what the spinal cord sort of serves, there is sort of the main, the spinal cord going up and down, carrying signals that have to do with motor and sensation. And those functions we categorize under something called the somatic nervous system, which really just means the part of the nervous system that is under voluntary control or under conscious awareness. So that often has to do with, our moving our muscles, or our ability to feel something as sharp or hot or dull or rough. There's another, perhaps equally important in many people's view, part of the nervous system, which is called the autonomic nervous system. And that has to do with a lot of the oftentimes involuntary parts of what the nervous system controls, and things that may be operating under a level of awareness, such as breathing, heart rate, blood pressure, temperature, bowel and bladder function. So I think to make this analogy a little bit easier, we'll just talk more about the somatic part, the motor and the sensory function. And I think it's important to note that there are, it's a two-way road. There's descending fibers that come from the brain down, and then at different levels, and I think you can see these cross street, but at each level it can go out. This is the first wire that goes from the brain to the spinal cord, and then at each level there's a second wire that exits and then goes out to the part of the body that it innervates. So that's motor function, but there's, and then this was to illustrate that, the signal is carried down to the muscles, and that's how you get movement. Similarly, there is the ascending sensory tracts, where sensations that come from the body, such as heat or vibration, it gets sent to the spinal cord. So then the spinal cord carries all that information up to the brain. So again, these are some of the main functions that people who've had transverse myelitis see deficits in, and that comes from sort of the anatomy of the spinal cord. And this word transverse really refers to it being sort of a cross-section that oftentimes when somebody has transverse myelitis, it affects both the ascending, the sensory pathways, as well as the descending motor pathways. When myelitis strikes, and it really is, it can be very quick and tragic and unexpected, just like a car accident, we get sort of signals not going up and down the spinal cord as it usually would do, and as a result, signals don't get carried in terms of movement or sensation. And then I think it's important to point out, again, there's really two wires, and knowing and understanding about the different wires and the patterns of deficits that they create is helpful for people to understand sort of their type of myelitis. So there's the upper motor neuron, sort of wire number 1, that comes from the brain and goes down the spinal cord. And usually with transverse myelitis, it's sort of a cross section. It affects both ascending, so leading to pain and numbness, or descending, leading to weakness. And then the type of picture that you see is often something that is classified as spastic, which means that the reflexes are often increased or brisk, and the tone can be very tight, and people can have spasms or contractions of their muscles when they don't mean to have those. And another way of thinking and conceptualizing of this is sort of, these are the white matter tracts. Myelin often helps insulate the neurons, and it helps perpetuate the signal at a faster rate. So you can think of these as sort of the high-speed areas of the spinal cord, and hence the myelination. On a different note, there's another pattern that we've really gotten to know more about in the last few years, especially in children, called acute flaccid myelitis. And the damage there isn't so much in sort of the broad highway of the spinal cord, but the level where the second neuron kind of branches off of the spinal cord. And with this, you get a different pattern. weakness is also involved because without getting that signal to the muscle, it's not able to contract as well as it could be. But the reflexors are often decreased, and the tone can be floppy, or also referred as flaccid, and so that happens to be related to the second wire. This often, this is called the gray matter because there's less myelin in this part of the spinal cord, and it's where sort of the cell bodies of the second motor neuron live. And in many of these cases, for some reason, it doesn't seem to extend so much to the sensory parts of what the spinal cord carries in terms of that information. So people may have varying degrees of sensory involvement. And here's a kind of what the spinal cord really looks like. And for the most part, I think the analogy holds. I think the one thing I would point out is, unlike kind of the central up and down highway, in the spinal cord, the myelinated area is actually sort of around the perimeter, and then sort of where the second neuron comes off is actually in the center of it. And then there's sort of two areas where it comes off. Sensory information goes from the parts of the body here into the spinal cord, and then the motor information goes out that way. So I guess I'll pause first. If anybody has any questions about that, I'd be happy to answer that. I know that's sometimes dense, but hopefully that analogy helps some people who may not have really conceptualized, the difference between transverse myelitis and acute flaccid myelitis as much. Okay, so moving on to some of the new developments in the last last year really. So the CAPTURE study is a study that is a partnership between multiple centers, healthcare centers in the United States, Canada, the Transverse Myelitis Association, and most importantly, patients. This study in particular enrolled pediatric patients. It was funded by a patient-centered organization in the United States called PCORI. And the real goal of this is to understand, not so much what doctors view as important goals, but what patients really want in terms of, the interventions they want. We want to know what sort of measurement, what barometer that patients really feel is important to their recovery. So there's kind of several parts to this project. First, to assess what the current state of our ability to understand and treat transverse myelitis is, and what the typical outcomes are with our current standard of care. And then with this natural history data, we are able to then do interventional trials to see, do these interventions alter the natural history of transverse myelitis in any meaningful way. So here are a bit of the sites, here for people not as familiar, we're down here, and then a lot of places in the Northeast and really throughout the country are involved. We're very happy to have their collaboration. So far, so in this pediatric population, it seems to mirror a lot of things that we know from adult studies, that the gender ratio is pretty much 50-50. We saw a peak of incidence in the August, September times of the year in 2014 and 2016. And I think that is attributed a lot to the acute flaccid myelitis epidemics that happened there, at least in our North America, and we'll talk a little bit more about the acute flaccid myelitis in subsequent slides. The symptoms seem to be more commonly affecting legs rather than arms, and that often makes sense because, at a higher level, arms and legs get involved, but if it's lower in the thoracic or lower spinal cord, it's often just the legs, and anything above that level seems to function fine. Urinary retention, which is more of a characteristic of spasticity, is often seen more commonly than a flaccid or incontinent bladder, but we know that people who have urinary retention can have symptoms of both. In most of these centers, IV steroids was the first-line treatment in the majority of time, but followed by IVIG, or intravenous immune globulin, as well as plasma exchange. And then reassuringly, a lot of the functional measures that we use seem to suggest that these children had pretty good functional independence. And this is a kind of a broad measure of a lot of activities of daily living that have to do with grooming, dressing, eating, carrying on daily functions that may not all relate to walking, but it is, I think, reassuring to know that many of these kids do go on to be pretty full in terms of the things that they can do. And I'm happy to announce that with the incoming Lubin Fellow, I think one of his key projects will be kind of recapitulating the capture in an adult population. So kind of switching gears a little bit more to acute flaccid myelitis. Again, I think it's important, and it has been something that I've been interested because we tend to see this more in younger patients. But I think it also echoes, you know, I think I heard Ross say that your organization serves post-polio patients. So I think this is a way to understand those patients and the specific pathology that they have. Again, this results from damage to the number 2 neuron, the lower motor neuron, which starts in the gray matter of the spinal cord. And we saw clusters, again, of these cases sort of in, you know, our North American fall of 2014 and 2016, and it primarily occurred in children. There's a thought that this is different from transverse myelitis in that it's directly related to a virus causing injury to the spinal cord rather than what we think in most cases of transverse myelitis, which is the virus or the bacteria has come and gone, but a confused immune system does most of the damage. The recoveries, unfortunately, has been slower and less complete in this population compared to transverse myelitis. And the treatment with immunotherapy is controversial, and you know, I think it's logical to conclude if this is really a process driven by a virus, then perhaps suppressing the immune system doesn't make so much sense as for transverse myelitis. So in the patients that we followed and seen at UT Southwestern, this analysis includes 44 patients. The average is fairly young, under 9 years old. Again, pretty equal female-male ratio. With a follow-up of about 17 months, we found that 61% had either excellent, very good, or good outcomes, and good is under what is called a modified Rankin scale of 3, which means that for many of these patients, they require some help in daily activities, but for most of them, they're able to walk. And then, interesting enough, you know, in certainly 2014, we've kind of conceptualized this as a primarily gray matter type of myelitis, but actually looking at the data combined between 2014-16, we often saw sort of a mixed picture where there was also some white matter involvement, and I'll talk about why that's important in the next slide here. Here are a few pictures of what transverse myelitis, or sorry, pardon, acute flaccid myelitis in some of these kids could look like. So they had parts in the brighter white areas, that's where sort of the abnormal parts of the spinal cord are. So it can be sort of on the periphery, that's the white matter. It can be in the central cord, so kind of just right in the middle, affecting both gray and white matter. When you see this kind of H shape, that's usually more of a gray matter predominant pattern, and sometimes we even see something that I've seen referred to as owl's eyes, where it's really just the anterior horns, which is where poliovirus really affected, and we've seen that pattern a lot in our acute flaccid myelitis patients with presumably enterovirus-related disease. And then I think these two are in the same patient. So even though you can see gray matter predominance, there's also the potential that at different levels of the spinal cord, you may have some overlap where the injury and the inflammation kind of crosses over to the white matter. And I think that the reason that's important is we think that the gray matter primarily has to do with the virus causing injury, and a lot of that cannot be helped with some of the immunotherapies that we use. But where there is white matter involvement, where there's that more of a spastic pattern of weakness, there seems to be a role that things like IV steroids, IVIG, and plasma exchange can help with. So I think, you know, our goal in sort of disseminating this information, you know, as we're getting into, you know, August, September, October of 2018, we're hoping that, you know, this continues to skip years and we're not having an outbreak of this every 2 years. But I think that the role of anti-inflammatory and immunomodulatory therapies should be studied better, because it seems like from our experience, people have had better recoveries with more aggressive immunotherapies. Okay, and then this has been an area of interest particular to me. So I think one way to think about this is I think many of you may know what aquaporin 4 is, which is the protein that seems to be what the body attacks in terms in the disease neuromyelitis optica. for a long time we found kids who had a very similar picture to neuromyelitis optica, but they didn't have the aquaporin 4 protein. But we had an idea that something immune mediated was going on, and it turns out many of those kids have a antibody to MOG. So this is a protein in addition to other proteins on the myelin sheath, and it probably does something to provide structural integrity to the myelin sheath. It can cause really a broad array of syndromes, even more than neuromyelitis optica. It can result in transverse myelitis, optic neuritis, which is swelling and often vision loss related to optic nerve involvement, ADEM, which can affect the brain and the spinal cord, and it can also really result in something that's optic nerve and spinal cord predominant, looking like NMO. So I think the importance of being able to recognize and test for the SMOG antibody is that it represents an identifiable cause of transverse myelitis, unlike many of the idiopathic transverse myelitis where we're not quite sure. And because that this is an antibody-mediated syndrome, there is a potential that sometimes these patients will have relapsing illnesses, and being able to know that somebody is MOG positive can tell us if they may benefit from ongoing therapy to suppress the immune system. So since I think October of 2017, we've been able to test for MOG in the United States through the Mayo Clinic. I'm pretty sure in Europe, Oxford does it. I would think maybe in Australia, I think Russell Dale and Fabian Brulot and University of Sydney, they may offer it on a research basis. I don't know exactly where they are in the commercial availability, but especially in our younger patients who have transverse myelitis and who've had more than one attack but are negative for aquaporin 4, we've been really suggesting that people get tested for this because it could impact management. And the way we've been handling it is we will, test any of our kids who have acute kind of demyelinating syndrome. If it's negative and they're also negative for aquaporin 4, then they're likely to have a one-time monophasic disease, or it could be multiple sclerosis, because unfortunately we don't have an antibody for that. However, if they're MOG positive, then it's helpful because it argues against the diagnosis of multiple sclerosis. And we've really not seen anybody who's been positive for both MOG and aquaporin 4 antibodies. I think where it becomes more challenging is, what do we do with that information? What we've been doing is testing it again after 6 months. And if it's persistently positive, I think that increases our threshold to treat, because that may be an indication that the immune system is still confused and may be at risk of having another attack. Whereas if the antibodies go away, that often means the immune system sort of corrected itself and is no longer confused, and that that first attack is probably the only one that a child or adult will have. So we're working together with other centers in the United States and across the world to really try to formulate guidelines that we can use and apply, and then study this population in further detail. So shifting gears a little bit to finding treatments for the disease, and I think everybody should be reassured that these are some of your experts. You're in great hands with some of these people and helping make steps in hopefully the cure, or at least the improvement of function in transverse myelitis. Before I talk a bit more in detail about the studies, I just want to go through a quick refresher of what clinical trials and the timelines look like. I think this is both a blessing and a curse. It's a blessing that we're able to be very proactive about protecting patients in terms of drug safety, and having anything that's approved by the FDA or other drug agencies be really validated to be helpful and not cause any harm. But I think the downside of that is this often is a very long process. There's 3 phases before a drug can be approved. Phase 1 really has to do with safety, and it can test the intervention in either healthy volunteers or people with the condition. It's often the shortest and the smallest, or they enroll the least number of patients. Phase 2, it becomes a little less about safety and dosing, but more about how effective a drug is, and they can expand this to tens to hundreds of people, and it tends to take a little bit longer just to recruit that number of people. At this stage, some drugs, they don't make the cut in terms of effectiveness, and they may not make it to market. And phase 3 is really when most people in the public hear about drugs. That's when they're really expanding it to hundreds to thousands of people with the condition. And they're looking for sort of more uncommon adverse reactions that they may not have found with kind of smaller populations. And this is often the most laborious and time-consuming parts of clinical trials. And then sort of in the end, I think, less than 10% of trials really make it through this whole process, unfortunately. Or fortunately, if you think about it, because then, we don't want ineffective or harmful drugs being, taken to market. And then the work doesn't necessarily stop after the FDA approval. There's still kind of the post-marketing phase where, drugs, after they're introduced to a very large population, sometimes we find, more uncommon adverse events, and that has led to, many drugs to be withdrawn at that point. So in terms of people who have neuromyelitis optica, or a relapsing form of transverse myelitis, it's great that for such a rare disease, there are 3 drugs that are in the phase 3 portion of their study. And, very importantly, they all have different mechanisms. Terminal complement really means the last step in which an antibody causes injury to the cells. So being able to intervene at that last step often means that diseases that are mediated by antibodies can be improved. You may recognize CD20 as Rituxan or rituximab or ocrelizumab or Ocrevus. Those are current medications that are available that target B cells, but this one targets a slightly different part of or slightly different population of B cells, and it's more the more mature B cells that are the ones that are kind of the factories of producing antibodies. So we think, we hope that intervening kind of at a later stage of the antibody and decreasing the antibody producing cells, that we can provide some improvement in these conditions. And then IL-6 is sort of an inflammatory mediator in the blood, and it's been shown in a similar, an analog of this drug has been shown to be helpful in some rheumatologic conditions, and we hope to see the same for neuromyelitis optica. Again, I think it's very hopeful that these will be approved in the next couple of years. And I think many of these mechanisms may be helpful in other immune-mediated diseases. So I think that really goes to show that even if a disease is rare, there's a lot of potential to bring about drugs that are not available and have them be used off-label for other conditions. And then definitely I want to spend some time about recovery. So after you've had the transverse myelitis, what are your options in terms of improving your strength, sensation, improving pain? And I think looking sort of at the anatomical basis of what happens with transverse myelitis can be helpful. The obstacles in terms of repairing a damage to the spinal cord, there are natural neurons and support cells, which are called glia, that get injured and sometimes die in the process of the inflammation. And sometimes a scar can form, and then even just that physical scar can interrupt signals from going up and down the spinal cord. Oftentimes there's not complete transection or cutting of the wire, but just the insulating cover is stripped, and the body has some innate potential to repair myelin, but that often goes at a fairly slow pace. So what can we do in terms of boosting the positive stimuli that increases the speed of myelination, and then also maybe decreasing some of the molecules that are present that may be putting the brakes on the myelination. And I think these are sort of the drugs that I've heard most about. They're being studied in the multiple sclerosis population, but once they're approved, I imagine that they can be used off-label for other types of demyelinating conditions. One targets a factor that suppresses the innate body's process of myelination, so kind of stopping the factor that kind of puts a brake on the myelinating process. And then kind of on the flip side, RIGM22, which stands for recombinant human IgM22. It promotes remyelination kind of by boosting up the positive stimuli that causes the oligodendrocytes to repair areas of demyelination. And then I think probably spend some time talking about to me, I think one of the most exciting part of myelin repair and recovery, which is stem cells, and for a number of years, patients have been asking about sort of what stem cells can do for the recovery of transverse myelitis. And I think now we're closer than ever to come to see this as a reality. We're not really using, we don't want the stem cells that can have the potential to become any type of tissue in the body that would be sort of counterproductive. We don't want, because stem cells, they can grow to be hair, they can grow to be teeth, skin. Certainly nobody wants any teeth growing in their spinal cord. So I think we have to be judicious and very regimented in how we approach these therapies. So in terms of where stem cells are going in terms of transverse myelitis, we're looking at particularly cells called glia, and these are the support cells for the neuron. So here's in yellow the neuron, which is what forms the cable transmitting the signal. But in order to function well, it really needs sort of these support cells, these oligodendrocytes, which are having these little appendages going out to make this myelin on the axon. They're very important, obviously, to improve the speed of the signal and the strength of the signal. And then there are also cells called astrocytes, which produce growth factors. They can eliminate toxins, and they can prevent injured motor neurons from being further injured or perhaps dying. So in terms of the upcoming stem cell trial, they will be using these particular glial cells. It's a company called Therapeutics, and they already have very good robust studies in rodents, models of multiple sclerosis, ALS or Lou Gehrig's disease, and spinal cord injury. And luckily, it doesn't appear to be any significant toxicity. They seem to do what they are meant to do, which is to differentiate into these support cells and not other types of cells that are, existing in the body. They seem to have a way of honing in and going to the motor neurons that seem to be injured or at risk. They can enhance the motor neuron survival, and then oftentimes these stem cells can mature into the myelin-producing cells, the oligodendrocytes, and potentially cause some remyelination. How this works, one more slide before that. And again, I think this is a slide from the company itself, but I think it's really great to see transverse myelitis, in the same kind of classification as other diseases, which are arguably more common. And transverse myelitis is, in the late stage and about to roll out in the phase 1, which is further than a lot of other studies. So actually that will be coming out fairly soon. I think the tentative date is in fall of 2018. So in the US, the FDA has approved a phase 1 trial to study the potential of these cells and see if they can repair myelin damage. UT Southwestern here in Texas will be the first and only site performing this trial. 9 patients will be initially enrolled. And it is an invasive procedure. It's not without risk. It involves actually directly injecting these glial cells into the spinal cord. So certainly all of these patients will be people who have the disease and are fairly severely impaired. They're not able to walk. So we just want to limit the risk to people who have better function. We do not want to introduce cells that could be potentially dangerous into someone who has preserved walking. Because again, with anything that's foreign to the body, there's a chance that the body can reject it. And even though it seems to be safe in mice, we just want to make sure that that also translates to humans. And again, the fall of this year is when it's supposed to roll out. And then I think, again, nine people is not very much. It's in the phase 1, so there's certainly a lot more work that needs to be done before this may be a therapy that's widely available. So for an individual who has transverse myelitis, what kind of things can you do to really actively help your daily function, and what things can you promote? What sort of healthy behaviors can you promote so that once these therapies come online, that you are good and you are able to benefit from these therapies? And I think that has to do with a lot of rehabilitation, preventing kind of the unfortunate secondary side effects of having had transverse myelitis, which has to do with kind of care of all the bones and joints, and then promoting healthy behaviors through things such as mood and better sleep and exercise and diet, which all of us can do. So I wanted to talk a little bit about activity-based restorative therapy. I imagine many of you are familiar with this. This is therapy based on the principle of neuroplasticity. It requires activating kind of above and below the level of spinal injury, and it's really just helping to kind of wake up those neural pathways, promoting new connections from developing, restoring the function of pathways that may not be in great communication, and kind of just connecting the paths where they should be. There are 5 key components. First is weight-bearing activity, so that's great for osteoporosis and preventing osteoporosis because any sort of weight-bearing activity can help strengthen bones. Functional electrical stimulation, which is putting either kind of electrodes or pads onto parts of the body on the muscles that with kind of a pulse of current can help those muscles fire. And the benefits of that are twofold. First, it helps the muscle prevent the muscle from atrophying just by leading to that contraction. And then some of that signal probably makes it all the way back to the spinal cord. And having that signal is helpful to say, you know, hey, there's still, you know, we're still working here. So can we help reshape and reform some of those connections so that the function can be partially restored? And then it really matters, you know, the kind of the environment and the activity that people do. We want to use activities that are sort of applicable. So either walking, moving the arms and legs, you know, the therapy that people do for people who've had, you know, a fall and had a hip broken, or they have had a spinal surgery for slip disc, that's a different type of PT, so we really want to promote the types of tasks that people want to be eventually doing. And then repetition is certainly the key of success, so just lots and lots of repetitions so the body can, you know, get that signal and really learn and, you know, cause beneficial connections to form. And then locomotor training is a big part, so kind of putting everything together and getting to the point where, you know, many people want to be, which is ambulating, walking, kind of putting all those components together has been really important. And then just kind of a general slide about things that you can be doing. You know, if you're not able to, your mobility is limited, then it's very important to prevent things like pressure ulcers from forming, blood clots, which can form when somebody doesn't have as much mobility. Osteoporosis, bones get thinner and weaker with age and also with less weight-bearing activity. And then when people have spasticity, sometimes that can lead to contractures forming in the joints. Certainly exercise has numerous benefits, not only for transverse myelitis, but pretty much, you know, any condition, cardiovascular health. Exercise seems to also be very helpful to improving mood. And, you know, mood, I think, is often sometimes people will be dismissive about it, but it really does make a big difference because your mood affects how you perceive things like pain, how you perceive the benefits, you know, of therapy, and it helps with motivation. So being able to kind of target maybe negative or maladaptive coping behaviors can be really helpful. And then sleep is intricately related to mood as well as fatigue. So if the sleep is not good, then it's really helpful for people to talk to their physician. Is it because they're waking up too much at night to have to use the restroom? Is it because they're having sleep apnea, because maybe some of the respiratory and the muscles in the throat are weaker because of the result of the transverse myelitis? So any of those things that you can intervene to improve sleep has been really hugely rewarding for many of our patients. And then I think the research in diet and sort of what the gut microflora has to do with these inflammatory diseases are really exploding. I think that the most robust data is on taking vitamin D. We know people who have inflammatory diseases are less likely to have recurrences if they have a good vitamin D level, and people just across the board, if they have a higher vitamin D level, they're less likely to have things like transverse myelitis. And then just screening for age-appropriate diseases, cholesterol, high blood pressure, cancer, and then preventing those cardiovascular risk factors such as smoking, lack of exercise, and so forth. So pretty much closing out here, I just wanted to highlight the Transverse Myelitis Association is an incredible resource. There are podcasts, there are videos available on YouTube that go over, way more than I've been able to talk about with many experts from many different centers in the U.S. and across the world. And then in particular, 2 efforts I wanted to highlight include the Eclipse Fund. Many of you know, the tragedy of Pauline, who we lost last year. I had the pleasure of meeting, was just incredible inspiration in her and Sandy's tireless efforts really serve the basis of where we are in terms of the state of research and the discoveries that we're making today. So, thinking about this fund, we really want to catalyze a speed of research. So just encourage people to look into this and support in any way they can. And then the Transverse Myelitis camp is available to families of children who've had these rare immune diseases. It's incredible fun. It usually happens in July, and it occurs in Kentucky in the United States. I think we've had at least 1 family from Australia in the past, and certainly we welcome many more. With that, I'd like to thank you very much for the opportunity to come address you today. I'm happy to take any questions and like to thank you again, as well as the Transverse Myelitis Association. Here are some pictures from one of these camps and then a whole camp picture. And then let's see, I'll maybe exit my screen, but that's my email if anybody, certainly I'm willing to address any questions that you may think of later on. So hopefully didn't lose the connection. I think everybody's still there. Again, it's good to see everybody. I was just looking at my slides the whole time. So again, open up to the room and any questions that may be coming through the portal.
So, Cynthia, can you hear me from here?
Yes, yep.
So what I might do is ask if anyone's got any questions and try and relay them to make sure they come through clearly. So does anyone have any questions for Cynthia? Yeah.
So just nutrition and diet is the only control I seem to have at home. Is there anything Dr. Cynthia can say towards what helps in the way of diet or nutrition?
So, Cynthia, the question was about the controls that this person is using at home about diet and nutrition, and asking about any guidance or protocols around diet and nutrition.
Yeah. No, I think diet is certainly an area there. A lot of people in these inflammatory autoimmune diseases are putting a lot of efforts into. In terms of specific diets, I think what we generally recommend is just healthy Mediterranean style diets, a lot of fruits and vegetables, just because the nutrients that you need to function well and provide the energy to do daily tasks. It seems to be those foods and less processed foods. I would say in terms of potential supplements, certainly vitamin D, in terms of things that we often recommend for promoting myelin repair and certainly shouldn't cause any injury, are things like omega-3 fatty acids, something called alpha lipoic acid, which is also a kind of a constituent of the fat in myelin. And then for energy, sometimes people have had success with things like coenzyme Q10 and something called L-carnitine. But in terms of diets, yeah, I think the field is moving toward understanding not just what's in the diet, what's in the food themselves, but also the effect that the diet may have on the microbiome and the gut. We know that there's kind of always a tug and war between certain classes of bacteria in the gut, and some tend to be more inflammatory and promote maybe leakage and break down the blood-brain barrier and the gut barrier, and then there are the more perhaps protective microorganisms that help seal up the layer and prevent chemicals, toxins from coming in and out of the body. And probably what some of the benefit of diets are is that they promote a better balance of the helpful bacteria and kind of counterbalance the negative bacteria. So I would say stay tuned. Probably in the next few years we'll be able to give you a better idea, but I think Mediterranean diets or paleo diets, those just tend to be more healthy for cardiovascular health and for cancer risk. So that's what we typically recommend. I know Dr. Greenberg, oh, go ahead.
So I was just going to ask a follow-up, Cynthia,
Sure.
about does the TMA or does University of Texas Southwestern provide protocols or generic advice that someone can get advice from a nutritionist or doctor from?
I know there's an effort that one of the multiple sclerosis doctors, and if you give me a moment, I might be able to find it. But one of the multiple sclerosis doctors, Dr. Darren Akuta, he works with a physician assistant, and they together have developed an app that they kind of put recipes on that they tend to recommend for their multiple sclerosis patients. And let me see if I can find it. I just don't remember the name, but let's see, 1 second. Yeah, I don't know if you can see. It's called Plant Process. Maybe you can see here, but that's an app that you can get through at least the iTunes store, and it's pretty great. I think all of these recipes are made by the physician assistant, but there are there are pictures, there are recipes, and then these are typically things that, certainly won't hurt you. And then there's some, perhaps evidence to suggest that these foods may be more anti-inflammatory. So I'd recommend checking that out.
Okay, and just before I take another question from the floor, sorry, a follow-up on that one, Cynthia. Is there someone in the States that you're aware of that has done significant level of research in the gut microbes and their influence on things like MS?
Yeah, I think in terms of the pediatric, a lot of people have looked at pediatric MS because, you think that children who get the disease very early, they must have genetic or environmental risk factors that place them at higher risk. So there's a lot of work coming out of UCSF, University of California, San Francisco. And the person, I think, who has been the primary investigator is Dr. Emmanuel Wabant. Her last name is Waubant, Wabant. So I think in the pediatric population, she's looked at things like sodium intake, and there was some mixed results, but it seemed that less sodium seemed to be somewhat helpful in maybe decreased risk of these inflammatory diseases. Less fat intake. Seems to be a connection with obesity, having lower vitamin D, and then developing some of these conditions. Again, I think this mostly applies in multiple sclerosis, where there's certainly a risk. There's a high risk that they may have relapses. In the idiopathic transverse myelitis population, I would say just do it mostly because it's good for you, just across the board. And then if you were to have a relapsing condition, that would be less likely. But I think most of these are just helpful just to prevent you from developing other autoimmune diseases, because we really haven't seen somebody who has had idiopathic transverse myelitis happen again or have the attack again. And then I think there was another person, but I probably won't remember his name. But if I think of it, I'll send the email to Jeanette, I guess. But yeah, he, I think, is somewhere in Delaware. If I think of it, I'll say it, but it's not coming to my mind right now.
Think of it later on tonight.
Yeah, right. Middle of the night, I'll wake up and it's like, that's the one.
Yeah, okay. Sorry, did you have a follow-up question for that? Or, okay, Louise.
I just thought of it. His name is Lloyd Kasper. Lloyd Kasper, Kasper. He's wrote a number of papers having to do with the gut microbiome.
All right.
And I think in terms of multiple sclerosis, there's been a couple pretty interesting studies. One looking at, I don't know how they found these people, but twins, like identical twins, where there was one sibling who had MS and one who didn't. And they saw that the gut microbiome, when they took it from the person who had MS, it seemed to induce sort of a rodent picture of multiple sclerosis, whereas the healthy, non-MS twin, they didn't have the same effects. So again, you know, all the articles, it's not like, you know, there's 1 or 2 bacteria that are always there. It's sort of the ratios and perhaps the balance of the bacteria. But yeah, I think there's a lot of suggestion that maybe something has to do with the gut, and maybe that's the first, you know, the first inciting factor, perhaps, and maybe infections have something to do with promoting, you know, some sort of breakdown in the gut or the blood-brain barrier. But yeah, I think probably in the next few years we'll have a lot more, I think, more definitive and research-based things to tell you.
Okay. Louise?
Just from an Australian perspective, one of our members, Professor Graham Martin, who lives in Brighton, his wife Janet is actually a dietitian and nutritionist who tasked herself with finding out everything she could in terms of diet and every aspect of diet, so that she could, if possible, use that as part of an ongoing support for her husband's condition. So we did have a talk with her, an informal talk with her a number of years ago, but I think maybe it's time that we could perhaps include her in a future event if people are interested. And today, obviously, people have shown that they're interested, so I think it's great that we've potentially got an Australian perspective there that maybe that would help.
Okay, so Dr. Wang, we've got a local support, like a spouse of someone living with TM who's spent a lot of time researching informally, I think, nutrition. So qualified dietitian. So we'll try and combine both of those sources of information and maybe do a session later on this year.
Great, yeah. I know in the multiple sclerosis population, there's been interest in this specific diet called the Walls diet. You may have heard of it. It's WAHL '(S) Walls. This Terry Walls is a physician who had multiple sclerosis, and she changed her diet and sort of her rehab routine and seemed to have really good results. So there's nothing in it that I think would be harmful. So, but if somebody is interested in reading about it, there's not much in terms of randomized control studies that would support it. But I think there's really no harm in trying that, and it's a more healthy diet than most of our Western diets. So it's interesting to read about and look into if you haven't heard about that.
Okay. Did anyone else have questions?
Is there any online questions?
Yeah, Jim, are you there? Were there any online questions?
Cynthia should be able to see them as well. Is there any online questions?
No. Scroll up a little bit.
Oh, okay.
I think it's okay. Oh, it's possible to see the slides, hopefully.
So we will upload the
presentation.
Yeah, Cynthia, I'll get you to send me your copy of the slides, and I can upload those for people to view later on.
Excellent.
Cynthia, while people are waiting, straining their brains to work out another question, I had one about early on in your presentation. You referred to steroids being the first line of defense. What has your experience been at trying to influence the application of those steroids? Like in Australia, I know it's probably mirrored in America, the lack of knowledge or lack of understanding of the first line physicians or the accident and emergency paramedics about the possibility that something is transverse myelitis or TM related. Mm-hmm. Has UTWS Southwestern undertaken any influencing role to try and increase awareness of the application of steroids and things like that?
Yeah, I think it's certainly, I think working in this academic center, I think most people, when they hear transverse myelitis, they often do know that, the first line therapy is steroids. But I think what the challenge is often, somebody coming into a community hospital or rural hospital with symptoms that, could be neurologic or it could be something else. And really the thought that this could be transverse myelitis just doesn't arise for that individual. So, we've seen people who just, been told to take some non-steroidal medications because they think it's probably a slipped disc or a a pinched nerve or something musculoskeletal, because by and large those are more common things in a population level. But I think we've been trying to do education in an effort with the Transverse Myelitis Association, other organizations, just to really bring about awareness that if there is ongoing symptoms, somebody's gotten to the point where they're not able to walk, they have like spasticity in their legs, they have high reflexes, and those may take a while to develop. But if there's something that is very different, then to think about further studies such as doing spinal imaging or performing a lumbar puncture to see if there's any inflammation. And I know other people are looking into other forms of myelopathies. Dr. Carlos Pardo at Johns Hopkins, one of his areas of interest is differentiating myelitis from other myelopathies, which there may not be such an inflammatory basis, which he mostly studies vascular myelopathy. So if there's a blood flow issue to the spinal cord, that often can bring about a picture that looks very similar to transverse myelitis, but the difference usually is that those vascular related myelopathies, they happen much quicker. So on the order of minutes, hours versus hours, days, possibly a week for transverse myelitis. So yeah, I think we're doing the best educating our residents, and I'm very fortunate to be a fellow trained in these things, and I'm currently slated to stay here at UT Southwestern, but certainly all the trainees that we work with, hopefully they've had it ingrained in their minds that these are the red flags that should tell you to pursue more workup, and then if it does look like transverse myelitis, then immune therapies are the things to go to. So yeah, so I think it's an ongoing effort.
Okay.
I have one.
Oh, sorry, Louise. There's another question up the front here.
Just acupuncture. What's Dr. Wang's thoughts on acupuncture?
Okay, Dr. Wang, the question was about what's your thoughts on acupuncture for transverse myelitis?
Yeah, I think where we've seen the most success are people who have neuropathic pain, especially if people are intolerant to some of the medications because of side effects, or they just want to try an alternative and perhaps, a more natural approach. I don't know exactly the specific, mechanism that it works, other than it's probably, causing, signals to go differently. I think there's certain points that have to be used, and they've done studies where they just blindly put in needles and it didn't work, and it seems to be really based on some of the Asian forms that they've really refined, and I think it may have to do with where nerves are connecting. So in pain, you may know that the reason why there's neuropathic pain isn't because there's tissue injury. Like, we get pain most of the time because there is something we did that's actually causing tissue damage, but neuropathic pain is pain without tissue damage, and where we think that signal goes awry is that the connection from the spinal cord is interrupted. So you're not getting the full information, and the brain has this pesky way trying to make up things, and often those can be interpreted as painful signals. So I think probably the way acupuncture may work is that it will maybe blunt some of the the misfiring or the excessive firing of those nerves. So I think people who've done acupuncture, probably in our clinic, there's been like a 50% rate of success. So I think if that's available to you and you're able to see somebody who is reputable or certified in acupuncture, that would be certainly something worthwhile. Yeah, I think equally there have been studies of something called dry needling, and I don't know exactly where the distinction lies between that and acupuncture, but I know at places where are focused on spinal cord rehab, like Kennedy Krieger in Baltimore, I've seen that their therapists will do something called dry needling. So maybe something you can look into too.
All right, thanks.
Just to follow on the types of therapies that people are often given in the early stages of their treatment, is steroids, as we know, is a well-known and widely accepted kind of treatment. In Australia, IVIG has become much more readily available in the last 5 to 10 years and is being used as a complementary or as an alternative treatment. The one thing that I'm aware of around Australia is there's a great deal of resistance to the use of plasmapheresis or plasma exchange. So as a question to you, in terms of efficacy, how does plasma exchange actually, is it being seen to have a significant impact on patients? How important is it? And how much should we be working on Australian doctors to say, hey, consider this as an alternative if you're not getting results from steroids or from other things?
No, I think that's an excellent question. Certainly, I don't think anybody would disagree that steroids should probably be first line because it's, the easily accessible. There's the lowest potential for, serious side effects because it's not as invasive and usually doesn't have as many, carries so many side effects as IVIG and plasma exchange. I think it becomes difficult sometimes, and it really depends on availability. Where I trained in Michigan, especially in a pediatric hospital, I can only think of maybe one patient that we did plasma exchange, and it really had to deal with the comfort of, I think it was a pathologist in administering that treatment, and then you have to get surgery to put in a central line, especially in a child. They can't get that therapy through a peripheral IV. So a lot of it, I don't think is so much based on data, which I think many lines of data suggest that plasma exchange is probably the most effective treatment for transverse myelitis. It really just has to do with resources. And then I think it also has to do with sequencing. I would say if somebody has transverse myelitis does not significantly improve on steroids, then I'm often looking for what can I use next in terms of, so here we're lucky to have sort of all three of these modalities available to us, but I think where the kind of the tricky part lies is if we were to give IVIG and it didn't seem to work, and in our experience, it seems like it works less well than plasma exchange, then the next step would be plasma exchange, and that really requires taking out all the antibodies that we had just given with the IVIG, so that's a very expensive mistake. So just in terms of sequencing, we often will do steroids, and we get a sense pretty quickly if somebody has a very severe transverse myelitis, and oftentimes we'll do steroids, and the next day the person goes for a central line to get the plex, and we do that pretty much concurrently. But then I think, once we have that, we're still looking at IVIG perhaps after steroids and plasma exchange. But I think for places where where plasma exchange is not readily available, I would say for sure it's probably helpful and certainly not harmful in most cases to follow steroids with IVIG. I think the issue with all of these therapies is that since there's often a delay between first, the second, and the third line, there is a natural recovery that happens that, regardless of whether somebody gets treatment, over days to weeks, the natural progression is that the inflammation will die down and things will get better. So is it really that, IVIG or plasma exchange is more helpful, or are we simply giving it after steroids have had a chance to work and, some time has elapsed since the transverse myelitis event? So those aren't quite clear to me. I know people have tried to do randomized controlled trials, but it's just very, very hard to do that in a safe manner and to recruit people. I think one of the previous Leuven fellows, Dr. Alan DeSena, wanted to do a project like that, but I think it's a hard sell to our institutional review boards to do a sham or kind of a fake plasma exchange, like putting in a central line and then basically running the machine without anything happening. So I think we always have to balance sort of the risks of the patient. So unfortunately, we can't really do studies that collect that kind of high quality evidence.
Okay. Yeah, so
There's a question online.
if we just take one from the floor, please, Cynthia, first.
Following on from the question about plasma exchange, is there a time limit on when that should be administered, and or can it be administered to someone who has had TN for almost 10 years?
Yeah, I think I heard most of the question. Like, are these therapies potentially effective? Yeah. Go ahead.
So I think the point of the question was, is there a time limit on when plasma exchange would be considered to be effective treatment? Or is there a cutoff when it would no longer be considered an effective treatment?
Yeah, I don't think there is a firm and hard cutoff. I think it's certainly case by case, but I would say generally after 90 days, whatever inflammation had ensued is pretty much just died out. Like, we often use this analogy of a fire, and the fire can, it can go on, but it doesn't go on forever. And usually 3 months is about when inflammation, even if untreated, doesn't tend to stick around. So I would say for people who are, several years out, I think that these treatments are less likely to be helpful, especially in the monophasic idiopathic transverse myelitis. But if it's someone who has a relapsing form of transverse myelitis, then it certainly can be helpful, because then there is inflammation that's potentially going on. And I think that really goes to, people often ask, like, how do I know this is a new attack? It feels the same. I have the same symptoms. And I think the way we try to think about that is, how long are the symptoms lasting? Are they, similar to old symptoms that you've had before? Are they in a completely different, limb? Completely different. If it's brand new, that certainly raises concern that it may be a new inflammatory attack. And then symptoms that persist more than a few hours, certainly if it's going on, for several days, and not decreasing, then we certainly recommend people go to their primary doctor and maybe get some testing to make sure they don't have a urinary tract infection or a pneumonia or anything that could be predisposing them to be having more symptoms in the setting of their body, kind of not compensating with a stressor. But yeah, I think in general, I would focus more on things that improve sleep and fatigue and exercise and rehab, more than the immunotherapies for somebody who's had what looks like idiopathic transverse myelitis and are more than several months out from the initial attack.
Okay. Sorry, there was one question online. Can you see the question, Cynthia, from where you are, or do you want us to ask it?
Maybe if you could see it. I don't see it for some reason.
Okay.
The question is about someone relapsing every time they're taken off steroids.
Oh, okay.
Although she's on mycophenolate. Scroll down a bit. She's done IV steroid therapy twice and on tablets, and now taken off slowly again. What can you suggest should be their next direction in terms of treatment?
Yeah, so I think because this individual is on mycophenolate, or also known as CellCept, my guess is that she has a relapsing form of transverse myelitis. So first, I'd be curious, does she have neuromyelitis optica, and does she have the aquaporin 4 antibody? If not, and it's a relapsing form of transverse myelitis, then it would be certainly helpful to send that MOG antibody I was talking about earlier. It is, for all intents and purposes, still treated the same way as aquaporin 4 neuromyelitis optica, but I think it helps in terms of giving a better sense of long-term prognosis, because it tends to be a bit more favorable, the MOG-related NMO, than aquaporin 4. And then in terms of having, we use things like CellCept or Rituxan because we want to spare the person from having to be on long-term steroids. So, are there other things besides steroids that could be helpful? Has this patient, is he or she on the highest tolerable safe dose of the mycophenolate, or is there a possibility of going up higher? Has this person tried the other first-line therapy, which is rituximab? And then if it is somebody who fits criteria for neuromyelitis optica disease, then we have the 3 drugs that are coming out hopefully in the market in the next 2 to 3 years that have different mechanisms of action and may be helpful to this particular individual.
Okay, so the individual's just given a little bit more information, saying it's over a span of 2 years, and also due to long-term steroid use, she's got osteopenia. So can her GP or specialist be referred through to Dr. Greenberg to seek some additional advice?
Yeah, absolutely. I think he's very open to taking calls from other physicians, and see, I don't know the best way. I don't know how we've handled internationally, but I think if you search just his name, there's like a number and some contact information for our clinic. And oftentimes if a GP or primary care provider is able to contact him, he will call them right back and give some advice. It can't be, you know, particularly specific advice, but it may be general advice, like in patients who look like this patient, this is what we've tried and this is what's been done to be helpful. But yeah, I think in addition to Cellcept and Rituxan, we've done other things with neuromyelitis optica patients or people who have recurrent transverse myelitis, and that may include regular IVIG infusions or regular plasma exchanges. I think we've done anything from every 2 weeks to every several months. And you know, certainly none of those are very fun, but if it's, you know, at a point that this person is having significant osteoporosis or osteopenia, it may be worthwhile to talk to their neurologist about whether those therapies are possible.
Okay.
And then, yeah, and then quickly, just in terms of the 3 drugs that are coming into the phase 3 trial, I believe at least one of them, the tocilizumab or the SA237, there's an analog of that is currently being used, I believe, in maybe psoriatic arthritis. So oftentimes we've used some of those medications off-label because they are available on the market, but just not for the indication of neuromyelitis optica. So she can look into perhaps that medication. It's an IL-6 inhibitor or called tocilizumab, TOCIL. IZUMAB. Sorry, too many syllables.
Okay, we'll pass that information on. Are there any other questions from the floor here?
Yes, please.
Yeah.
Hi, Cynthia.
Hi.
Just a question regarding ADEM. I'm post 3 years, told it was 99% sure. What's the reasonable amount of period to wait? It's definite. I have improved.
Yeah, I think what we tend to do in ADEM population is that in our clinic we will follow up somebody with ADEM for at least 5 years, and then, you know, if really nothing happens at 5 years, I think it's pretty low likelihood that they would have a relapsing form of an autoimmune condition such as multiple sclerosis or neuromyelitis optica. Related to aquaporin or MOG, but certainly if you've been tested for aquaporin and it was negative, getting some additional information with that MOG test may be helpful. That MOG seems to be more related to ADEM than say aquaporin 4. So, you know, it would be helpful to say, I think it would be helpful to argue against a recurrent form. And then certainly the longer you have not had symptoms or had any attacks, I think the more reassured we should be that this was a one-time event.
Thank you. Oh, one other thing, sorry. I believe in August this year, Brisbane is hosting the Global International Neuro-immune Conference.
Wow, okay, wonderful. Incredible. Is that is it transverse myelitis related or just your
global?
Oh, okay. Wonderful. Yeah, that's really exciting.
Coming.
Yeah, I mean,
able to access it, you have to be Neuro-immune or whatever. So yeah.
Okay, good to know. What is the official name of it? Like, I'd be interested in looking into it. The International.
Yes, International Neuro-immune. It's the global conference. I think they have one every 2 years.
Okay, great.
I haven't heard of it either, but I'll look it up.
Yeah.
Okay.
Yeah, I think I've been seeing, like, I've been able to find like many lectures, and for people who haven't looked through the Transverse Myelitis Society, the podcast or the YouTube channel, there are like dozens and dozens of lectures spanning all the way back to, I think, 10 years. You can see Dr. Greenberg when he was just a fresh, I think, recent fellow graduates. So yeah, and unfortunately, looking at some of the things, they haven't changed that much. But again, I think with this stem cell trial, that's just been, it's been a long time coming, and it's been a long process that things like that are finally coming along. So, but yeah, I encourage most of the things, looking through some of the old talks, I think most of the same things apply, and probably the only new things we're able to test for are things like the aquaporin 4 and the MOG. And then probably in the last decade, the activity-based restorative therapy, there's been a lot more evidence to suggest that's helpful. And we always like to encourage people, people always ask, like, when does recovery stop? And I think it's always hard to answer that, because I think it really just stops when you feel like that your time limit is up and that you can't recover. So if you stop, trying to continue to do the different exercises and rehab, then that's when we see people not make those goals, because there's been a change of behavior. So even with our Acuteflaccidmyelitis kids, several years out now, they seem to be making small improvements. We've had a transverse myelitis patient who had, I think, TM in infancy, and now she's nearing 18, and like 10 years after the event, she said, oh, I can wiggle my toe, and never was able to do that before, and now she's getting up in a standing frame and doing lots of functional electrical stimulation and getting some movement. So yeah, I don't think there's never a time limit on recovery, but just be kind of prudent about how you do the exercise. Make sure you're working with someone who sort of knows this condition, and it doesn't have to be somebody who knows transverse myelitis, but people who've worked with people who have spinal cord injury, they often know the same techniques that seem to be helpful. So.
Okay. There are any other questions? I don't think we've got any other online questions. So if no one else had any questions here. Dr. Wang, thank you very much for giving up your time on a Sunday night. It is greatly appreciated here over in Australia. Thanks very much for your informative presentation and for taking questions from the floor and online. We'll look up that conference and see if you want to come to Australia. Come to Australia.
No, let's see if I can get Dr. Greenberg to pay for it.
Well,
I might want to come along too.
I'm glad you volunteered the payment. I think it might be a fight for Dr. Greenberg, actually. I think he's keen to visit as well. But thank you very much for your time. It's a wonderful for you and Dr. Greenberg to give so freely of your time when you could be doing other things, including family time. So we greatly appreciate that. So if we can give Dr.
Yeah, happy Transverse Myelitis Day. All right, take care. Bye-bye.
Thanks, Dr. Right. We ran a little bit over that, but I think it was worthwhile offering some little bit more time for people to ask questions and hear some answers from Dr. Wang. We had scheduled a 10 to 15 minute break for everyone to stretch their legs and grab a cup of coffee before we move on. Did everyone want to do that? Yeah, okay. So feel free, there's tea and coffee at the back, and Terry and Jeanette will be able to help you with tea and coffee.
I'm pretty sure that the here, I thought, I'm going to go and sit on that, but you can't get into it. Like, it's not, I thought I was happy to pay just through that.
Do you hear me, Jim? That didn't turn the volume off, did it? No, because we had that off before. Hey, Jim, you there?
Terry's calling. Make sure you're not recording this bit.
Yes, the recording started.
Okay, thanks.
Okay, so if I could call everyone to order. Thanks for taking the time to give me a chance to run out of the room and do something else, but also to network. And Donna has joined us, so welcome.
Thank you.
You didn't miss, well, you missed a really intriguing speaker in the first section, but we've got it all recorded for you to look at later. It covered quite a few topics, so I think she was a very engaging speaker. So thanks for all your questions in the last session. What I thought we'd do now is introduce you to another staff member who works here at Spinal Life Australia in the member services area. with our 1,500 members across Queensland, one of the things we say to people is to remember that you're not alone. That it sometimes feels like that you're out there by yourself trying to change a local issue or address a local challenge that you've got, or deal with everything from your wheelchair manufacturer or supplier right through to Centrelink. It can feel quite isolating. One of the things I'd like, and one of the things we're introducing, Terry, today, is I'd like you to remember, if you're a member of Spinal Life Australia, you get access to a whole range of advocacy supports and guidance and advice, and someone to share your ideas and challenges with. So we do a lot of advocacy for people and with people, and we have for many, many years. So advocacy at the moment sits in 2 different places across the organisation. Terry can explain a little bit more. So Terry Slight is the advocacy advisor for Spinal Life Australia. The reason we're introducing Terry to you as members is to remember that Terry's there. So if you have a challenge in real life and you want some advice and guidance, or shoot the breeze with someone who might have known someone who's faced the same sort of challenges, Terry's your guy. All right, so Terry, I can introduce you. Terry will give you a bit of a rundown on advocacy within the organisation and take any questions you've got. Thanks, Terry.
Hello, everybody. I'll reassure you before I start that I'm a better advocate than I am a public speaker, so I apologise in advance. So I don't know if you guys have used the advocacy service at Spinal Life, but sometimes it can be a little bit confusing about what that means, because as an organisation, we often say we advocate for people with spinal cord injury, TM and post-polio, or we do systems advocacy, so we try and influence policy, but we also do individual advocacy. So my role here is as an individual advocate, which means I'll work with you directly if you have a concern. So basically, regardless of all the other terms we use for advocacy, if you are a member, you have a disability, and you feel like you've been treated unfairly, you can call me and we can work through whatever that issue is.
What's your phone number, Terry?
Exactly, that's it. I could get there, that would be enough. So in terms of some of the work I've been doing lately, it's been a lot to do with the NDIS. So this has a very formalised structure of how decisions are made, how decisions and equipment are rejected, and how you appeal those decisions. So in terms of just as an example, NDIS will make a decision. If it goes against you, you can appeal that decision within 3 months. If that goes against you again, you can appeal that within 28 days, and that goes outside the NDIS to the Administrative Appeals Tribunal. At that point, the NDIS will often engage an external law firm, and at that point, I can get involved as well, so it's me against a law firm. So that's what sort of services we can offer here. Some of the other things I've worked on recently are disability support pension access, disability support pension meeting the points requirements, citizenship status for disability support pension, disability discrimination in terms of workplaces, but also physical access to public buildings. So if a building's been built recently and you can't use it because of your disability, you're being discriminated against. So again, call me and we can work through that. So in terms of how this is different from the organisation, so we've been making a bit of a push lately to be more involved and more structured around how we do advocacy at Spinal Life. So advocacy, that's not my role, but advocacy, that's how we kind of place the organisation. We are developing a new advocacy charter, which just outlines what we believe in and things we're going to work towards in the future. So we've been going out to members and approaching them lately to get ideas on where they want to see the organisation fight for them. So we've been working on a number of position statements, and they include employment, accommodation, transport, health, equipment, accessible communities, and research at the moment. So these would be publicly available and kind of updatable on an ongoing basis. So the members of the organisation can influence what we do and where we're fighting in the community for you. And I guess as an example of the sorts of challenges in that sphere, so in the systems advocacy sphere, people with disabilities in the aged care system is currently quite a major problem. So on top of the, say, 100,000 people on the waiting list for their appropriate home care package, people on higher level aged care packages can't get subsidised equipment through the government structure. Whereas if you're on a 1 or 2 package, you can. So that's a systems issue that we're going to fight in the future. And I guess it's just an example of where we might head, going forward. But again, this is different to my role. Today, this is just introducing me and to bring it back to individual advocacy. If you remember, you have disability and you've been treated unfairly, then I can offer free service to help you through any kind of issues that you may have. And that's how I'll follow that.
Any questions?
Questions, anybody? Obviously, my service is also it's confidential, so often issues are quite sensitive, and so it's a completely confidential service if you want to contact me at any point. But if you guys do have any questions now that you'd like to raise, maybe I can take a shot at answering any kind of funding issues or NDIS.
So if I've got a problem with Centrelink or Night Care, can I appoint you to act on my behalf, or can I appoint you to inquire on my behalf rather than spending half my life on the phone? Yeah, had to know where I was going. So is it a way of you actively helping rather than me sitting on Centrelink's wait list on hold?
You can actually, yes. You call Centrelink, or you call NDIS, or you call the organisation that you are involved with, and you tell them that I'm your advocate, and you give them enough identifying information that when I call, they can say, I can prove who I am, and then I can speak to them on your behalf. And that's not me making decisions for you. That's just me spending the hour on the phone for you and telling the organisation what you would have told them if you happened to have called. And I mean, that's not necessarily the most difficult part of my job, waiting on the phone, or what I enjoy doing most. However, it's a lot easier in some cases for me to do it than for you to do it. So phone charges, reception, all of that sort of thing. But in basically any organisation, you can appoint somebody to be your advocate, and that can be me, and I can contact them on your behalf.
So you don't have a line into someone more senior within the organisation where you can bypass all these wait on the phone for hours, and there's no arrangement whereby whomever it is that needs your support could come and say meet with you, and you can have a conference call with whomever's on the other end and maybe work it through quicker rather than being there for the telephone tag that'll happen by the time you relay information backwards and forwards and all those other things.
That's a really good question. I think the answer is we don't have any formal arrangements in place, but sometimes you can get to different people in the organisation, from Queensland Health right through to the Chief of Staff and Minister's Office and things like that. So there is no one answer to the question, I guess, from my point of view. I don't know whether you've got anything to add.
No, there's nothing on paper that says that an advocate has any more access or clout than you do. However, if I approach somebody as an advocate from Spinal Life Australia, they know that we have a specialty in this area, so we know what we're talking about. We're backed up by hundreds of years of experience in spinal cord injury with 1,500 members around the state. So it's not just one person then. They're talking to 2,000 people. So it can escalate your status within. Yeah. And they don't enjoy having somebody looking over their shoulder. So often when an organisation like Centrelink speaks to an individual, there's not really the checks and balances that should be in place. But when they're speaking to an individual and an organisation or somebody there fact-checking basically what they're saying, they get a little bit uncomfortable in a good way for you.
Mm-hmm. So is anybody else having trouble with disability pension and that side of things with the new changes to the, because I'm apparently not disabled and I do get a disability pension and my appeal has been turned down as well.
Yep.
So when the original application in an appeal because of the new changes that were made a couple of years to that structure and the waiting list, the 2-year wait.
Yep.
So I have to satisfy work or study within those 2 years. Is there a way around that?
So
I am actually disabled.
Yeah. So half a dozen years ago, they tightened up the rules around disability support pension and did a lot of reviews. So a lot of people who were formerly on disability support pension got bumped off and made to reapply under stricter, and some would say unfair criteria. I did something like this a week ago, and I know a process where you can, if you like, go back through the spinal injury unit to get reassessed for the points of the table, table, to meet, for instance, because you have to get 20 points in a single table to make it severe.
Yeah, I've got that. I've satisfied that.
Okay.
It's actually the capacity to work.
Oh, yeah. Yeah? Well, it's kind of the same thing when I happened. At the time, I'd left my job. If I was in the workplace, I would have been able to access my superannuation component for partial, temporary disability.
Yeah.
Yeah, but because I'd left my job and I'd gone past a 6-month period, I couldn't access that. I couldn't access anything. I was just lucky that I got a partner who could do that for me and my family. So, yeah. So you can go for years without nothing.
Quick answer, I don't know. As I said, this is Spinal Life, so we can look into it and see if we can fix that work capacity, right?
Yes, yeah. You've got to prove a certain percentage that you cannot be retrained or yeah. It's a fight, hey?
It's far.
And that's why
I get offended.
And people get, it just pushes you backwards and backwards. You can't try
that's
to
why we're
improve
keen
your
on
health.
introducing theory. So when you are facing a fight, you can realise, or you can be reminded that you're not alone. There's someone that maybe has helped someone before you do a similar thing, or someone who can go and do some research and maybe offer some general guidance and assistance. We don't try and take over advocacy for people, because the vast majority of our clients, unlike other disability support agencies, don't generally have a cognitive impairment. You generally know exactly what to do, when to do it. It's just maybe the hows you don't understand, or whether there's precedents being set. So hence the reason to introduce Terry. If you're a member of the organisation, you're a member of 1,500 to 2,000 people, depending on how we present ourselves to government agencies, to funding bodies, not only to take up the big causes, but to try and help you solve the individual challenges.
When did you actually start this business at all?
This particular
No, this
NDIS.
Checking people to see if there's work available and that.
For the disability support pension. What did you say, 6 or 7
I had a phone call about 6 years ago, or less, actually, from a political office, wanting to know whether I wanted to go back to work.
Can you vote for me?
I typed on the back of the letter the reply. It looked like an official letter, and said that I started work in December 1958 when I finished school at Agricultural College. I finished up work in 2009 where I was working volunteer for Centre Care at Caboolture, having just done their database to agree with the HasLink database, as it was at the time. I think you should be getting someone else. I'm 68, 69, and your latest work retirement leave is 67.
You're the reason they keep increasing it.
Yeah.
You've got to get Al back into the workforce.
So I'm looking forward to getting another one in the next couple of weeks. I could write back and say, I'll be 70 bloody 5. And I put that last bit with the red line under it and send it back to Mr. Swan's office.
You're in his lecture, aren't you?
No.
Oh, no.
No, I'm in Longman.
No,
Yeah, so we're going like
Are there any more advocacy questions, please?
As a facilitator for the TM network, I think all the years and all the people that I've spoken to, there's a couple of things that stand out as recurring kind of observations, and that is often people are trying to deal with big and government or, you know, systems that they've never had anything to do with before, and you're trying to do it at a time when perhaps you're feeling least empowered because you're trying to deal with a rare disease that with a medical professionals, many of whom sadly stand at the foot of your bed and Google TM. I don't know if that's an answer to you, but it is horrifying as a patient to be depending on Mr. Google to find out.
Dr. Google.
Dr. Google, well, yes. But one, I've worked very closely with Terry, and I've often put questions to him or raised issues that come from individuals in the TM network, and asked him to sort of follow up. And then I like to try and keep in touch with what actually the outcomes are, just for my general information. So if I get another question or something about that particular concern, that we can build up a knowledge base that because I think empowering people, helping people to take back the kind of control that they had, and it's a big part of our recovery. For me, it was a big part of my recovery. I always felt in control, very busy, and knowing what I wanted and when I wanted. But after getting transverse myelitis, I lost that confidence. So therefore, I think Terry's role is flexible enough that sometimes for a set time period, he can help you get back on track. So my question to you, Terry, is if people are beginning out a process of trying to deal with an issue with an organisation, is there steps that we should be taking along the way so that if we ultimately have to come for you for assistance, what would be most helpful for you to have in place for a person to be able to give you as an individual? You know, do we need copies of correspondence or records of telephone calls, or what is it that you can put together to help present a solid case?
The most useful thing would be a paper trail. So to explain the situation to somebody else, to me, and also in the future to prove your case to somebody else is a paper trail. So all the correspondence that you've had with an organisation, notes of phone calls that you've had, dates and times. If there's a simple chronology of events, often issues arise because people have different stories of what has happened. But if you have a record of what has happened, then yours becomes fact. So the most useful thing, getting back to the question, would be extensive notes on how those interactions have gone.
The story that's happened.
The story, yeah.
I would say one thing. My doctor has just signed me up. It's called My Health.
Yep.
And what it is it is open. You have the right to say who wants to see all your records. On the computer, they just click My Health, and all your records from your own doctor is noted. So, yeah, so I just feel that that's a paper trail, because I've had this 7 years now, and all my records for 7 years. So,
yeah.
And it's run through My Health. Yeah.
Health records are normally fairly extensive and fairly good.
Yeah.
When you get to records of administrative processes through aged care or Centrelink, that's where it becomes a bit, harder to trust the records. So, yeah.
Particularly if there's been conversations over the phone with
no correspondence attached to it.
Sorry, can I just ask everybody here, have you all applied or you're on the NDIS started happening for you?
In the process of it.
Yes, yeah.
Too hard for me. I can't put it in.
Some organisations will actually do it for you. My sister has spina bifida, so where she goes now and again for respite to give my mum a break or whatever, or she doesn't want to come to me, their coordinator does it for them. So all the paperwork works out the cost.
So we've got a
you do
whole
that.
team helping people transition to the National Disability Insurance Scheme. So if you're eligible and you're a member of us, we actually write to you before the NDIS becomes available in your area to say NDIS is coming on this date. We have done about 30 groups, information sessions about National Disability Insurance. So then we come in and offer you a one-on-one pre-planning meeting to sit down and work out, okay, here's some checklists about, here's the things you need to consider as you're going into your planning meeting for the NDIS. And then we'll come to your first meeting with the NDIS, the planning meeting itself, if you want us to. So that tends not to be Terry who gets involved when things go a bit pear-shaped. But we've got specialist staff that help you set up your NDIS plan, and Terry helps you get roadblocks out of the way if you want a quad bike. And other things, but
That's difficult with quad bikes.
So it's a really good question because we continually come across people with their heads in the sand about someone will come and help me do it or someone will do it for me. This is your opportunity if you're within the eligibility criteria for NDIS to take control of funding availability, to take control of the direction, of the level of care, and a lot of it falls to you and your preparation. Being prepared is the key to success in it, and we're here to help. So, like I said, if you're a member of the organisation, we'll write to you as a matter of fact, as a matter of course, because we extract data to say NDIS is coming, we offer you planning sessions. But if you've got any questions on the way through, call Terry, it's probably better than me.
Well, I'm at the stage where I'm just waiting for them to get back to me, which they said they'd do within 21 days on the 1st of February.
Which part of Britain?
Just in the western suburbs.
They are still doing, I know that I'm over your way, Springfield Lakes. They have someone that comes every month. It's a permanent day where you can go in and they can help you.
From where?
NDIS. Yeah.
So
I think they have different people in the community.
So that what used to happen, and it changes every day.
Yeah.
So what I'm telling you today may not be true next
Yeah.
week. So keep checking
Yeah.
back in because they're still, it's like my care, they continue changing. When they first rolled it out up north, they had supports coordination, and our agency would get funded a little bit to help you understand how to prepare, but also how to, once you got the funding, how to actually make it happen. They changed that and appointed local area coordinators. So when they did Ipswich, they agencies like ours were getting extra staff to help everyone, and then the Commonwealth goes, oh, we're going to change our minds, we're going to do it this way. So they appointed local area coordinators out in the community, and they took supports coordination away from agencies. So it changes all the time, but Terry can help with some individual advice for you. And he may not know the answer, but Terry's strength is the research on going to find the answer.
I would say that anybody.
Do they give you a contact? Yeah, well, I got the letter and I rang them in early April and they said, look, you know, we are so snowed under. You know, it could be forever before we finally get to you. But then I've since spoken to a friend who works at Disability Services and they're completely in the dark about all the employees, but that's another issue. But she advised me to email them so that I would have the paper trail.
Yeah. One of the benefits I found from attending one of the information sessions that Spinal Life Australia has run is that sometimes it's as simple as the language you use when answering a question can make the difference, because there's keywords or phrases that they've been trained to, if you say something, and depending on how you say it, and this shouldn't be the case, obviously, but if you've got access, I'd say educate yourself as much as possible. Use the knowledge base that sits in the NDIS team over there, because they're working every day with people who have are either on the NDIS or who are applying for it. And sometimes simply how you actually present a point, you know, why it's important for people with TM to have ongoing restorative rehabilitation therapies. And therefore, you might be asking them or including activities that are very, very appropriate for your ongoing health needs. Now, it's not something that's going to help you recover necessarily, but it's going to help minimise the backward sort of motion of things. So, you know, if you want to try staying as active as possible, but if you get knocked back on the ability to access those services, so although the NDIS mightn't pay for the service itself, but they might, under the normal course of events, help you access that service. So, I mean, it's something, they don't want to discriminate against you simply because you can't get to it or because for various other reasons. So I strongly suggest everybody takes a look at it, even if you're not presently considering the NDIS. It's good to just sort of have some general knowledge base, and don't leave it too late till you talk to Terry. Don't wait until there's been a lot of water passed under the bridge. Call him early in the piece, put him in the picture, and I've seen Terry guide a lot of people through processes that can help them develop a very appropriate paper trail, if you like. You know, how you document a telephone call that you make, the date, the time, the person or people that you spoke to, or, you know, how many hours did you spend on hold in trying to deal with this issue. All of that can be really relevant when you Terry's at some point in the future trying to assist you if you ultimately feel that you've been unfairly, you know, had a decision against you which you think is unfair or unreasonable. And I believe that
one of the things Terry mentioned before, the strengths of being associated with our agency is that the staff here have been working and supporting people with spinal cord injury and other spinal cord damage for many, many years. And so when you interact with an agency like Centrelink or My Aged Care or NDIS or the National Injury Insurance Scheme, they tend to not know much about spinal cord damage, which is where we quite often come in and go, well, this is standard for someone with spinal cord damage like this. And they go, oh, really? Can you give us a letter? So quite often we write letters or refer people to demonstrate that what you're facing, for instance, is part of the course, if you like, for someone in your situation. And we're like an external body that can help create some awareness in the funding agency.
Ross, I just remember there's hot food at the back.
Yeah.
And we're holding people up from that. Are you feeling sick? A little bit.
We didn't want to make sure no one burnt their mouth.
But I'm here for lunch, so if anybody has something they want to chat about,
Give him before he eats.
I'll be here.
So
He'll be here for a long time.
I'd like to thank Terry for coming along. Like I said, please don't forget you're attached to an organisation with over 900 people across Queensland, which include all our personal support workers across Queensland. So we're here for members, developing services or delivering services we think are relevant, so please let us know if they're not. Please use Terry and call him whenever you need a hand or some advice. That's the end of the formal part. I'd like to thank Jeanette Kretschmann for putting the day together. I'd like to thank Jim Lubin, who's online from Seattle.
Yeah.
So Jim helps us out with video conferences from the other side of the world. So he was hooking in someone from Texas, he's in Seattle, and we're over here. So Jim, thanks a lot for your help again.
Thanks, Jim.
Thank you, Jim.
Thanks, Jim.
Thanks all for taking the time to come along.
I think he's in Rochester, New York.
he really leaves his home. He is in Rochester, New York. That's right. He's a ventilator dependent quadriplegic. He got TM at 21, and so he's now
yeah. So he's ventilated quadriplegic. So he does all of this from his bed with his breath.
He's got a mouthpiece.
He's got a mouthpiece, so he hooks up.
He uses Morse code in the next advocate coming out.
Okay, so thanks a lot for taking the time to come along and meet us. There's lunch up the back, like Terry said, tea and coffee to the side. Accessible toilets on this side of the room is probably easiest across the corridor. Callum from our marketing, fundraising, communications would like to come in and take a few photos of people, because it's not often that we have the opportunity to get people at TM together. So if you're not averse to a publicity shot or a photo, that'd be great if you could volunteer and let us know you're willing for that, because it helps us generate awareness. After today, I'll go through some of the notes I made from Dr. Wang's presentation. We'll circulate a bit of a summary in the next couple of weeks, so please keep your eye out for that. Stay engaged with the organisation. We're trying to work on some other upcoming events. We've got monthly events of the Spinal Cord Injury Network here in Brisbane, so everything from hotel accommodation to transport to travel to a whole range of other things. So if you stay engaged with the organisation, you can pick and choose what comes available. If you're not a member, that's the easiest way to stay in touch. There's membership forms up front on our snazzy brochure stand. Otherwise, enjoy lunch. Thanks for your time.
Thanks very much, Jim. You can end the broadcast now.